Himani Upadhyay, Assistant Professor at UNMICRC Institute of Cardiology and Research Center, Ahmedabad, and today we are going to discuss Optical Coherence Tomography OCT guidance for percutaneous coronary intervention. So at first, what is the need of intravascular imaging guidance? With the help of conventional angiography, we images the lumen, not the vessel wall. It provides planar projection of the three-dimensional coronary tree, but there is poor inter-observer correlation and it is less sensitive for lesion morphology. With the help of intravascular imaging like IVUS and OCT, it provides tomography cross-sectional images with precise lesion characteristic, exact vessel size and lesion length, and it helps for better stent optimization. The basic principle of OCT is that it utilizes near-infrared light directed at the vessel wall through a rotating single optical fiber coupled with an imaging lens within a short monorail imaging sheath. By measuring the amplitude and delay of backscattered light, OCT generates high-resolution cross-sectional three-dimensional volumetric images of the vessel microstructure. Since blood strongly scatters light and attenuates OCT signal, flushing is required to displace the blood during OCT image acquisition. The basic difference between IVUS and OCT is that the shorter wavelength of the infrared light compared with ultrasound in IVUS, so it provides greater axial resolution 10 to 20 micron versus 50 to 150 microns in IVUS at the cost of lower penetration depth 1 to 2 millimeter versus 5 to 6 mm in OCT. So, because of the lower penetration depth, vessel remodeling is better defined in IVUS, whereas lipid core, fibrous cap, calcium, thrombus and macrophages are better seen in OCT. Limiting role of OCT in presence of highly attenuating structures such as red thrombus or lipid or necrotic core. So, let's have a look at the history of intravascular OCT and how gradually it stepped into coronary intervention. So, it was invented by Professor Fujimoto in 1992. Then in 1998, MGH cardiac OCT group was made for its use in coronary intervention. In 2000, first in human study was done, and in year 2004, time domain OCT got its CE mark in Europe. In 2006, the frequency domain OCT, which is nowadays used, got its CE mark in Europe. In 2010, FD OCT gets its FDA approval, and then in 2010 MGS OCT registry was formed with the Illumin 3 trial and erosion study. The various uses of OCT got expansion, and in 2021 it got recommendation in US guidelines. So the primarily invented time domain OCT was having a lesser pullback speed of 2 mm per second, which required proximal occlusion of the blood flow with a dedicated balloon and saline infusion from the tip of the occlusion balloon. So it was a bit cumbersome. Nowadays we used frequency domain OCT, which is having faster image acquisition with a faster pullback speed of 20 mm per second, and more than 50 mm length could be imaging within 3 seconds, and it does not need any occlusive balloon. So there is a picture showing the OCT console and rapid exchange catheter with contrast flush. As we can see in the image, the Dragonfly Duo catheter, it is having 3 radio opaque marker, a distal tip marker, a proximal marker and lens. There is 2 markers 20 mm apart for segmental length assessment, and there is a pullback length of 50 mm. The 4 P's, position, purge, puff and pullback, describes how to take optimal OCT pullback. The catheter engagement proper alignment is very crucial for the OCT pullback. In severely stenotic lesion, pre-dilatation should be performed. Cine should be performed during pullback to utilize contrast injection for angiography and for OCT co-registration if available in our system. Contrast flush rate is set at 4 ml per second for a total volume of 14 to 16 ml for left coronary artery and 3 ml per second for a total volume of 12 to 14 ml per second for right coronary artery. If autometer injector is used, the pressure limit should be set at 300 psi or nearest available. Saline OCT can be considered in patients with CKD and severe LV dysfunction. As we can see in the image, the OCT shows a longitudinal L mode and a cross-sectional images in B mode. Let's get familiar with OCT image interpretation terminology. So the first one is backscattering. The reflection of light waves of the tissue back to the catheter is called backscatter. High backscatter means a brighter pixel, also described as signal rich region, and low backscatter means darker pixel, also described as signal poor region. Then attenuation, the reduction in intensity of light waves as they pass through the tissue due to absorption or scattering. High attenuation means light cannot penetrate very deep, and low attenuation means light can pass through to allow visualization of deeper tissue. So this is the image of a normal vessel wall with the innermost layer that is highly backscattering or signal rich, that is the intima. Then there is a darker or low backscattering region, that is media. Outer to that there is a high backscattering layer, that is external elastic lumen lamina, and outer to that there is adventitia, a heterogeneous and frequently high backscattering structure. So the clinical applications of OCT are mainly atherosclerotic plaque assessment during PCI and stent optimization, and in stent restenosis evaluation, and in stent struts coverage and apposition assessment. For atherosclerotic plaque assessment, as we can see in image A, there is homogeneous high intensity signal suggestive of fibrous plaque. As we can see in image B, there is lipid laden plaque, that is low intensity irregular signal with high attenuation, and as we can see in image C, there is low intensity sharp borders with low attenuation, and that is suggestive of calcified plaque. So what is vulnerable plaque? The triad of a lipid rich core with a thin fibrous cap of a thickness of 65 micron with inflammatory cell infiltration makes a triad of vulnerable plaque. So these are again, the first image is suggestive of homogeneous high backscattering region of fibrous intima. Then in second image we can see low backscattering and low attenuating calcium. In third image we can see low backscattering and high attenuating lipid in the intima, and in the fourth image we can see clearly sharply defined low backscattering and low attenuating calcium, and in the fifth image we can see plaque with large lipid, heavy lipid burden, that is very likely a vulnerable plaque. We can also differentiate between white thrombus and red thrombus by OCT. So as we can see in image A, there is intraluminal protruding tissue with low attenuation and low backscattering of the optical signal, that is suggestive of white thrombus. Red thrombus is seen in image B. It is identified as high backscattering mass that protrudes into the lumen with signal free shadowing due to high attenuation. And in image C we can see recolonized thrombus. OCT can also very well differentiate between plaque rupture and plaque erosion. So if there is fibrous cap disruption with or without cavity formation, we can say that is a plaque rupture. And in case of plaque erosion, there is intraluminal thrombus overlying fibrous or lipid plaque without fibrous cap disruption, that is seen in second image. Endothelial disruption cannot be very clearly seen on OCT, hence it is identified indirectly by white thrombus on an intact fibrous cap, no thrombus and irregular lumen surface, or thrombus attenuating underlying plaque in absence of lipidic plaque or calcification. In settings of ACS, the culprit lesion can be plaque rupture and plaque erosion. There are more, that is more common, but it can also be a calcified plaque. That can be erective calcified nodule, superficial calcific sheath, or calcified protrusion. During acute coronary syndromes, OCT has got class 2B recommendation in EAC 2023 guidelines in cases of ambiguous lesion as hazy lesion, eccentric plaque, multivessel disease, tortuosity, or calcification. It can either be plaque erosion, plaque rupture, calcific nodule, scarred thrombus, or no lesions. So in ambiguous lesion, we can very well use OCT to define the lesion characteristic. Now, the role of OCT in PCI guidance and stent optimization. There is a mnemonic MLD max. M stands for morphology, L for length, D for diameter, then M for medial dissection, apposition, and expansion. So for lesion morphology, we have already learned the lesion characteristic before. This is a quick revision. Can the intima, media, and adventitial layers be visualized in the entire vessel circumference? If yes, then it is normal, or it can be a fibrous plaque. If there is a source of signal change, then where it is located? If it is located in the wall, and if it is having low attenuation, then it is a calcified plaque, which is obviously having sharply demarcated borders. If it is having high attenuation, it is likely to be a lipidic plaque. If there is source of signal change in the lumen with high attenuation, there is likely red thrombus, and low attenuation, then it is likely white thrombus. OCT allows determination of both calcium arc and thickness in most cases. The calcium thickness is not very well defined in IVUS, but OCT we can see it. OCT based scoring system for calcium, it is called as rule of 5. 1 point for maximum thickness of more than 0.5 mm, 1 point for contiguous length of calcium more than 5 mm, and 1 point for maximum arc of more than 50% of the circumference of the vessel, as in more than 180 degree of the circumference. So lower stent expansion in target lesion is expected when there is a score of more than 3, and it suggests that we should use calcium modifying techniques, either atherectomy or intravascular lithotripsy. So this chart depicts the use of OCT in selection in stent size and post PCI to see for any complication like medial dissection, under expansion, or malapposition. We can always use the reference diameter of the distal vessel for stent size, and with the use of automation, OCT automation, we can decide the stent length. So OCT in immediate post intervention for minimum stent lumen area, left main more than 8 mm square and non-left main more than 4.5 mm square are acceptable. More than 80% of average reference area or more than 90% of proximal and distal reference area are acceptable MSA post PCI. If there is dissection flap limited to intima less than 60 degree, less than 2 mm in length, that can be left untreated, but stent edge dissection more than 60 degree arc or more than 3 mm in length needs to be treated with stent. If there is any tissue prolapse, then it can be treated with post dilation with Henry balloon. Incomplete stent apposition. It is defined as strut vessel distance greater than the strut thickness. Strut vessel distance less than 0.2 mm for less than 1 mm length is acceptable. So these are the images. The first one is showing normal coronary artery. The second is coronary dissection with true and false lumen. The third is intracoronary dissection flap. And the fourth one is intramural hematoma. The intracoronary dissection flap and intramural hematoma should be further treated with stent. In case of IMH, we can also use cutting balloon for stent apposition, as we can see in image B. At 2 o'clock position, the struts lying at the 2 o'clock position, there is the distance between the strut to the vessel wall is equal to the strut thickness, and it suggests that there are well opposed struts. But at 4 to 5 o'clock position, the distance between the struts to the vessel wall is more than the strut thickness, so they are suggestive of malopposed struts. Now for ISR and restenotic tissue characteristic, OCT is very useful. A typical restenotic tissue of bare metal stent at early follow-up recognized as neointimal hyperplasia is primarily composed of smooth muscle cells and is visualized as a homogeneous structure by OCT. But the restenotic tissue of DASH, even in early phase, also demonstrates polymorphic pattern in structure, backscatter and composition. The term neoatherosclerosis suggests there is lipid-laden neointima with or without necrotic core, neovascularization or calcification, and that is more common with DASH than BMS. And for evaluation of stent thrombosis, DASH significantly suppress NIH. A study of OCT and IVUS demonstrate that 2/3 of the sirolimus eluting stent struts are covered by neointima less than 100 micron in thickness, which is beyond the resolution of IVUS. In recent years, the late stent thrombosis in patients treated with DASH has become a major concern. Strut malopposition, neoatherosclerosis and uncovered struts are the most common causes. The uncovered struts are most common causes for stent thrombosis, even in bioreabsorbable stent scaffolds. So for the follow-up assessment of stent struts coverage, as seen in image A and image B, the struts are uncovered struts, they are not covered with neointima, but in image C and image D, the stents are covered with neointima. So there is less chance of stent thrombosis. The first image showing restenotic tissue following bare metal stent implantation, that is homogeneous, whereas in image B, that is heterogeneous lipid accumulation with low signal area with a diffuse lumen border within the area of neointimal hyperplasia, and in image C, calcification within the neointima is seen after DASH implantation. Now let's see the artifacts in the OCT run. The first one is SUOP artifact. It is caused by combined rotational and longitudinal motion of the catheter that results in discontinuity between successive B scan. So it visualizes as slight elliptical distortion with visible stitch, as we can see in the image. The next one is non-uniform rotational distortion, NUR. It is because of non-constant angular velocity of the monofiber optical catheter. The disturbance in the angular velocity is due to mechanical rotational resistance, either due to tortuous vessel or vessel narrowing. that results in blurring or smearing in the lateral direction, as we can see in this image. Then due to inadequate flushing of the OCT of the coronary, there is residual blood, and it can mimic thrombus, it can cause merry-go-rounding effect. So signal rich areas instead of transparent lumen completely free of OCT signal can also mimic thrombus. Then fold over artifact. When the vessel diameter is too large for the field of view of the imaging catheter, OCT signal aliasing occurs and image appears to fall back on itself. This portion should not be used for geometry assessment. Then there is tangential light dropout. When the catheter is positioned close to the arterial wall, light emitted nearly parallel to the tissue surface, that part of arterial wall may appear to attenuate light. It can mimic thin capped fibroatheroma, lipid pool or necrotic core, as we can see in the image. Then there is sunflower artifact. After stent placement, when the catheter is at eccentric position, especially when the catheter is adjacent to the luminal wall, stent struts artifactually appear as a straight line perpendicular to the imaging light beam, and hence well opposed struts seem to be poorly opposed. These are the latest important trials for OCT. In Illumin 4 trial, the conclusion was among the patient undergoing PCI, OCT guidance provides a larger minimal stent area than angiographically guided PCI. Then in IVUS trial, it was showing that OCT guided PCI was inferior to IVUS guided PCI in terms of target vessel revascularization at 1 year. In October trial, among patients with complex coronary artery bifurcation lesion, OCT guided PCI was associated with a lower incidence of MACE at 2 years, and there was a meta-analysis of OCT versus IVUS versus angiography guided PCI, and the intravascular imaging guided PCI showed a statistically significant reduction in all-cause death, MI and target vessel revascular rates. Hence, it provides long-term good results. So, in real time, OCT runs might look a bit different from the textbook images. So, there are some OCT runs for reference. As we can see in this OCT run, there is high thrombus burden, and then there is lipid-rich plaque with plaque fibrous cap rupture with cavity formation, and that has caused ACS and STEMI for in this patient. In this second run, post-DES implantation, patient came with ACS and STEMI, and on the OCT run, we can see homogeneous NIH formation in the stent with MSA of 1 mm square. In the third run, we can see a fibrocalcific lesion with heavy calcium that is clearly defined with minimal lumen area of 2.7 mm square. That is the culprit lesion. And this is OCT run in post-PCI showing well covered studs. The stent is well opposed and well expanded except at the proximal end where the studs are a bit malopposed. It was further treated by NC balloon. So this is the basics of OCT and its practical implications. Thank you.